Superbugs will kill someone every 3 seconds by 2050 unless the world acts now. That's the dire warning about drug-resistant bacteria from British researchers. How has our abuse of antibiotics created a future where infections become untreatable? And what needs to be done to reverse the trend? This is Inside Story. Hello, welcome to the program. I'm Hazem Sika. Drug-resistant infections kill hundreds of thousands of people every year. Now, that total could soar to 10 million a year by 2050 because antibiotics are being overused. By then, routine operations would become too dangerous for doctors to perform, and a simple infection could leave you fighting for your life. For the first time, a major new report sets out what needs to be done to tackle the rise of so-called superbugs. Al Jazeera's science editor Tarek Bazley has more.
Many of the advances of modern medicine have relied on the use of these antibiotics. They've made previously incurable illnesses like pneumonia and tuberculosis treatable, and over the years they've saved the lives of hundreds of millions of people. But now those advances are under threat. The reason? The drugs have stopped working. Often unregulated and overused, both in humans and in animals, more and more bacteria have become resistant to antibiotics, and drug companies have failed to come up with new drugs to replace them. Former Goldman Sachs economist Jim O'Neill has spent the last 2 years investigating the problem for the British government.
The UK can do whatever it wants to solve the problem here in the UK, and I'm pretty hopeful that the UK will think of some ideas of how to respond to our recommendations. But because of the connectivity of the world and how people travel, how animals travel, unless the whole world does something, we won't solve it as a problem, including here in the UK.
The report details 10 steps governments around the world can take to address the issue. These include reducing and restricting the use of antibiotics in animals, developing and using more vaccines as an alternative to antibiotics, and requiring doctors to do tests confirming that antibiotics are required before they're prescribed.
The animal problem is massive. From the data we can see, and it's not perfect, in some parts of the world it is clearly a bigger problem than in humans, especially in the United States, probably also in China and India. So we need to have specific, dramatic changes taking place in the misuse in agriculture.
The report also says public awareness needs to be raised on a global scale, especially in countries where there's little regulation around the use of antibiotics. It also suggests governments might consider taxing the use of antibiotics, both to raise funds for research and to discourage their use. Above all else, the report underlines that this is a global issue and one that can't be ignored by any country, because to do so, it says, would imperil the health and wealth of the entire world.
Well, let's bring in our guests for this Inside Story, who all join us from London. Jim O'Neill, who we just heard in Tarek's report, led the global review on antimicrobial resistance. He's also a former chief economist at Goldman Sachs. Catherine Berry is an antimicrobial resistance expert with Médecins Sans Frontières, and Adam Roberts, a senior lecturer in the Department of Microbial Diseases at the UCL Eastman Dental Institute. Good to have you all with us. Jim O'Neill, let's just back up for a moment, first of all, and just explain to us how we got to this point. I mean, how did this problem become so urgent?
I think there's lots of answers, but I think the most simple one is that our civilization treats these things like sweets, whether it's for humans or in animals or in agriculture. And they are the miracle cure, but they're only a miracle cure for the things that really need them. And we overuse them and abuse them and misuse them. And that's at the core of the problem.
And we'll hopefully get into some of the main points of the report that you led. But just sum up for us, what do you think is the most urgent short-term need right now?
So in the report, we've actually got 29 specific recommendations that represent the sum of all our thinking over the past near 2 years. We've tried to highlight 4 big things that we think are crucial. The first of which, as your reporter touched on, there is a need for a massive global awareness campaign. Very few people outside the narrow scientific world even know that this is an issue. 2 years ago myself, when I was asked if I'd lead a review into AMR, I didn't really know what AMR stood for. I could give you many anecdotes of people who are generally very well informed and educated, just don't know. So can you imagine what it's like for those that are not fortunate enough to be educated? So that's a major thing that could play a role, as such public awareness campaigns have played another challenge of society and life around the world. Secondly, we need to do something dramatic about the way our doctors and medical practitioners interact with us as humans about antibiotics. We all wander around staring at mobile phones all day, all over the world, whether it's rich or poor. And yet our medical practitioners still use exactly the same subjective judgment, albeit highly informed, as they did in the 1950s, if not before. Study out in the US, just as we're putting our final touches to the paper, that showed that at least 1 in 3 antibiotics prescribed in the US isn't necessary. And that's almost definitely true, if not worse, out in the rest of the world. And so what we're suggesting is we need to dramatically boost the diagnostic market, and with it, and here's the particularly strong recommendation, is in the Western world, we should make it mandatory, and this is our recommendation, by 2020, that doctors cannot prescribe antibiotics unless there's been a surveillance or diagnostic test. Third thing, in agriculture, we recommend a global target with individual country targets to be rolled in over a 10-year period beginning in 2018. And we have some supplementary things as part of this target. We believe that so-called last-in-line antibiotics that are crucial to human beings should be banned for their use in animals and agriculture. All 3 of those are what I would describe as demand reduction interventions. The 4th crucial one, and I emphasize again, there's many others we're recommending, but the other big one is, of course, how do you get new drugs? And we're recommending something that we call a global entry reward, which directly compensates those successful pharmaceutical companies, I emphasize successful, that produce the right new drug, and as well agree to control its usage in a more disciplined way to certain criteria, and make sure through the right international links that they are affordable to the key parts of the emerging world. Last thing to say about that, we recommend importantly a whole different ways of how that can be financed. One of which is simply to use existing health budgets, but at the other extreme of about 4 different choices could be that the pharmaceutical industry itself collectively pays for these market entry rewards for those few pharmaceutical companies that are prepared to undertake this very challenging process.
Catherine Berry, what do you make of the findings and the recommendations of this report?
So MSF definitely welcomes this report. It's been a problem we've been fighting for many years, seeing in low and middle income countries, and we really value the fact that this report both makes it clear that this is a truly global issue, and also acknowledges that the main burden is going to be in low and middle income countries. The key for us is that right now we don't have the right diagnostics and the right drugs to deal with this. And really what we need to see is that there is good access and affordability for these agents going forward.
What do you make of the last recommendation in Jim O'Neill's report there about getting pharmaceutical companies to produce new drugs? I mean, what more do you think they should be doing that you believe they're not doing right now?
That's a really good question, and I'm not an economist, nor am I an expert in the pharmaceutical industry. We do know that from our experience with hepatitis C and with tuberculosis recently, certainly the price points at which those new agents have come to the market have certainly made making major inroads in middle-income countries in particular, who aren't getting the very cheap prices, very, very difficult in the settings we're seeing.
Adam Roberts, what do you think, I mean, how much is the average person at risk from so-called superbugs, do you think? And what can they do to protect themselves?
The average person's at risk quite a lot, actually. I'll tell you a personal story. 2 years ago, my daughter and I spent Easter in hospital at UCLH because she cut her leg, and the bacteria which infected her leg was resistant to all 3 antibiotics they tried, so they had to operate to remove the offending tissue before it went to the bone. So that was just a simple walk in the woods. So basically anything you do can result in a minor injury, a scratch or some way of bacteria getting into your body. Usually the body can cure it itself, but if not, we really are a society which relies on these antibiotics quite a lot. We've moved from a risk-averse society to one reliant on these drugs. So it's really important that this is solved, actually.
But we talked earlier about the need for more research and development, coming up with better drugs and so on. But that sort of thing is going to take years, isn't it? I mean, what can people do right now? What practical steps can people take to minimize the risk from these superbugs?
So, well, first of all, in terms of the public, one of the first points of the report is greater public awareness. And in this particular problem, the public have actually got an opportunity to drive change because they can do something about it. So things like finishing your antibiotics is an obvious one, which is often voiced, but also deciding where you're going to purchase your produce. If you choose not to purchase meat from a supplier that routinely uses antibiotics in their cattle feed, for example, you will drive change, and you can have the political impetus to drive the governments of the countries to change their policies as well. On a more personal level, there's really not that much you can do. It's in the lap of the gods, so to speak, because if you get an infection, you have no real idea yet whether it's going to be resistant. It's only if your body can't fight it, and whether you go to hospital or not to take the first line of antibiotics, which you'll inevitably get. 3 days later, if it's not working, you'll probably be given another one, and then you may start to worry. So there's really nothing you can do on a day-to-day basis to minimize your chances of getting an infection.
All right, I want to focus a little bit more on another area of this. Much of the discussion on superbugs centers around hospitals and pharmaceutical companies, but agriculture plays a huge part as well. Globally, farm animals were given more than 60,000 tons of antibiotics in 2010, according to the United Nations, and that number is expected to grow by 2/3 in the next 15 years. In the United States, more than 70% of all antibiotics go to animals. They're used to make healthy animals grow faster so farms can make more money off them, and that can lead to resistant strains of bacteria like E. coli and Salmonella that are released into air and water through manure. And scientists say antibiotic use in agriculture is driving about half of the resistance increase around the world. So, Jim O'Neill, how important is this area of trying to reduce and restrict the use of antibiotics in animals, and how difficult is that going to be to carry out? I mean, presumably you're going to get a lot of resistance from agricultural companies.
So it's the same as it is in humans. We treat antibiotics like sweets or candy as humans, and the animal husbandry and the agricultural industry effectively treats these things as sweets as well. And so the appropriate radical changes are necessary there. And as we've identified in our specialist report on agriculture some months ago, and also in this final one, it is clear in some parts of the world, probably the US, almost definitely the US, and big emerging countries like China and India, it's a bigger problem in agriculture than it is in humans, is our best guess. So we need to get some important things agreed. let me say in that regard, and I have some cautious optimism, and this is also true for parts of where the others were answering you. We think there are vital things coming up, even though our review is now over. But the fact that I'm a minister in the UK gives me some position to still have some involvement. The United Nations in September has a chance to have what is typically called a high-level agreement, in which a number of our recommendations or our ideas closely linked to them could be agreed by the UN. And one of those things we are recommending is about trying to agree a plan for the future, as I discussed earlier, to reduce the number of antibiotics used in agriculture, along with other things like compliance and stewardship, both in agriculture and humans. And then simultaneously, for the G20, historic moment being chaired by China for the first time, we think that is the right forum for some kind of agreement, also in September, as to how you can get some new drugs and how they might be paid for.
Catherine Berry, what's your take on this overuse of antibiotics in the agricultural industry? And is too much of this being left to market forces? Is there more that the governments can be doing?
So certainly my observation from my travels in Central Asia and other parts of the Middle East, that what the consequences of easily accessible antibiotics, certainly in humans, are, that communities are not necessarily as well informed as they could be about the consequences of misuse. Often they're getting information about how to treat their infections from their neighbour or from their community leader, and not necessarily from a well-trained health professional. And so the fact remains is by the time they often come to our care in settings, they've often had several rounds of self-treatment, and if it's a stigmatized disease like tuberculosis, that can be a major problem. In Uzbekistan, where I was in 2014, I would sit with people who tried to self-treat with treatment for a long time, and they were left with multi-drug resistant tuberculosis, and it's status normal there already, I can tell you. And we would be sitting there and they would be deciding whether they were going to take 15 tablets for 2 years or not to cure their TB. And we would go home at night and go, why is this so difficult? Why was this left so long? And why is there not faster action on this?
Adam Roberts, why do you think that is? Why do you think there hasn't been quicker action on things like this, on making these antibiotics available to people who need it most?
I think it's predominantly market-driven, to be honest. The lack of new antibiotics coming to market is purely explainable, and has been explained in the various reports from Jim O'Neill, that there's no profit in it. So with no new antibiotics coming to market, there's simply nothing left. So people have to rely on generics, and getting these around the world again it's just not happening.
Jim O'Neill, what's your take on that? That market forces in all of this are too powerful, and they're providing the main incentive for the pharmaceutical companies to act. I mean, how do you reverse that and get them to essentially do what's right?
So one of the main reasons why I, as an economist, I think was asked to chair this review is this is what you might call a classic externality stroke free rider problem, that we don't have the right forces in terms of commercial supply and demand that are influencing things that are global public goods. And so you either have to directly change the incentives, hence why the market entry reward for new drugs, or you have to do something dramatic in terms of philosophical, cultural and behavioural change. I think in this case you probably need to do both. But there are inherent contradictions all over the place, one of which is about the role of patented drug producers as well as so-called generics. And our specific recommendations of deliberately try to deal with all these contradictions, because you've got to deal with those to solve the problem. Another one that people don't seem to realise it unless you're really very specially focused on it. If we were successful with our recommendation about dramatically greater use diagnostics to reduce the demand, that in itself makes it even less attractive to commercial pharmaceutical companies left to their own devices, because they would not see the size of demand for a product that takes many, many years, even if they're lucky or successful to end up producing the product for. So the market entry reward that we have designed has been influenced by all these things, so that the pharmaceutical company gets directly rewarded for producing exactly the right kind of antibiotic, generally speaking so-called gram-negatives, that society needs. But in addition, as I said, I think earlier, also only on the condition that they try not to sell it all over the place as they might do with other pills that they successfully market, and play the same interplay that is happening, albeit not to a satisfactory level, but an improving rate, in our view, with generic companies to parts of the emerging world, so they can get the right drugs at the right affordable price. Because, of course, it is true in many parts of the low-income world.
All right.
A lot of them have a just as big a challenge that they can't get access to antibiotics. But the last thing we want them doing is getting more access and then going down their own path of excessive overuse of them.
Adam Roberts, how do you get doctors to more efficiently administer antibiotics? I mean, we were getting into that discussion a little bit earlier. I mean, requiring doctors to do these tests, confirming first that antibiotics are required before they're even subscribed.
Yeah, I think this is exactly what is needed, actually. Asking a doctor to decide whether to give antibiotics based on a few minutes of looking at a patient, maybe taking a temperature, is really arcane, actually. Technologies exist now where we can determine whether there's a bacterial infection in a few hours rather than days. And the technologies are being improved all of the time. So, for example, the Longitude Prize is aimed at producing rapid diagnostics, which are applicable anywhere in the world. And if you can imagine that, especially in the Western world, all of the doctor's surgeries have these rapid tests. So within 30 minutes, the doctor will be able to decide whether an antibiotic is appropriate simply because, okay, a bacteria is actually producing the symptoms. It's responsible for the infection rather than a virus. That would cut down dramatically on the inappropriate use of antibiotics. And every time we cut down the number of antibiotics we use, we slowly lower the selective pressure on the bacteria to develop resistance.
Catherine Berry, just briefly in the minute that we've got left, from the point of view of someone who works for MSF, what do you think doctors could be doing right now that they're not doing in terms of the way they deal with antibiotics?
I mean, my view on this would be it is very easy to put this on doctors, and I don't want to minimise the fact that improving the level of knowledge in medical professionals will greatly benefit this area. However, I think it's a partnership amongst many areas. It's about communities and certainly the doctors I see, they have a lot of trouble. They have a lot of pressure from patients threatening to sue them if they don't get the right thing, the thing that they perceive is the right treatment. So I think there are different ways we can support our medical professionals, and it's going to be a whole sector approach, not just the doctors.
All right, and on that we are going to leave it. Thank you to all three of our guests, Jim O'Neill, Catherine Berry and Adam Roberts. Thanks very much for being on Inside Story, and thank you for watching. As always, you can see this program again anytime by visiting our website aljazeera.com, and for further discussion go to our Facebook page. That's facebook.com/AJ Inside Story. You can also join the conversation on Twitter. Our handle is @AJ Inside Story. For me, Hazem, Sika and the whole team here, bye for now.